So let's move on to another interesting topic now: insulin initiation and intensification, balancing convenience with efficacy. And for this, we have Dr. Vagish Iyer. All of you know who Dr. Vagish is. He is an endocrinologist from Bangalore and is very experienced in his field. And he practices at Indiranagar in Bangalore. And he has many credentials to his credit. He is an avid researcher, a great academician, and a good friend. And I call Vagish to deliver his lecture.
Thank you, Neeta. Thank you for your kind introduction and kind invitation. So, yes, I think, yeah, it's there. Next 20 or 25 minutes, I will just go through my topic of insulin initiation and intensification, balancing convenience with the efficacy, how we do in our patients with type 2 diabetes with some case captions. Yeah. So this is a session by the Lilly, and I've been contracted by Eli Lilly for this meeting for delivering this lecture. So the most important is the insulin is used across the globe, but the patient characteristics are different. It's altogether different in the Caucasians and altogether different in the Indians, because we Indians, our muscle mass is different, our glycemic profile is different, and our lunch and our food intake is entirely different. So this is the one thing is our PPs are quite high for a given HbA1c compared to the Caucasians. This is the one study wherein they have compared the postprandial fasting and HbA1c, Caucasians and the Indians. And if you look into it, for a given HbA1c, take when HbA1c is on the lower side in this profile of a HbA1c, 8.2 is on the lower side. Almost the contribution is similar when it comes to the Indian population and the Caucasian population, just hardly a 10 different. But as the HbA1c worsens, when we move from 8.2 to 9.6 or a 9.8, see the huge difference in the postprandial contribution for the same given HbA1c. Their postprandial is just around 216 for 9.8, but our postprandial is close to 281. But most important thing is fasting is almost similar, 174 and 180, suggesting that for any given HbA1c, our PP contribution is high, but as the HbA1c moves towards the higher side, it becomes much more on the higher side. That's why the use of an insulin and what type of an insulin or what type of a premix insulin we use matters in the Indians compared to the Caucasians. That's why there was a national congress on the consensus on the premix was held in the presidentship of Dr. A.K. Das, our teacher, and they came out with certain guidelines and certain recommendations. So what they told is premix insulins are quite safe and their action is quite close to the physiological action of the insulin in the body, quite easy to start, and also we can intensify the same insulin. It's quite suitable and effective regime used by all doctors, right from the primary care to the even specialist. Compared to the Western recommendation, to some extent even the other recommendations where they want to initiate on the basal insulin to insulinize the person, premix may be a better to initiate in the Indians compared to the Caucasians. Only the advantage with this is it's quite simple. With a single injection pen or a vial will be continuing, and patients OHS continues, especially sulfonylureas. Quite effective in HbA1c control. They'll be showing the studies to prove that it controls both aspects of the glycemia, both fasting and a postprandial. With the same insulin pen or a vial, we can intensify the patient's glycemic profile, and also we can intensify for the glycemic control. But there are some concerns with premix. People tend to have more of a daytime hypo. Sometimes the midday or a evening snacking is required. Weight gain is more because you are giving more of a prandial insulin along with the basal. That's why the possibility of a weight gain is there. And also hypo to some extent adds to the snacking and a weight gain. Sometimes just 2 doses may not be enough to control the glycemia, especially the post-lunch. If somebody is taking a huge lunch, probably the post-lunch is not going to be controlled with just a morning premix insulin. That needs to be corrected in such cases. So this was a survey done by the authorities on the Indian physicians, how frequently use the premix in patient profile, whether it's adults, elderly with the normal activity, and somebody who is an elder but he won't be able to do all his daily activities. So when they surveyed it, they found that 60% of the adults use the premix twice daily, only 11% use the basal plus, and nearly 53% of the elderly people who are otherwise carrying out their day-to-day activities also use the premix twice daily. Only the elderly people who are frail, unable to take care of themselves, 23% use the premix. Otherwise, basal use was more among the elderly. Means when it is complicated, you want to make the insulin regime very simple, we don't want to produce any hypoglycemia, then probably the basal is a preferred choice. Otherwise, in most other scenarios, it is better to use premix twice daily to achieve the control. This is from the study known as an IMPROVE study. Then we'll come to a case profile wherein a patient who is taking a OADS, but his glycemia is not at control, how we are going to start the insulin in him. So this is a female patient of 54 years, type 2 diabetes for close to 12 years, HbA1c is uncontrolled, 9.1%. Patient weight has been stable since last, probably because of the glycemia is stable and also the exercise is stable. Patient is obese by Indian standards with BMI of 25.5. Blood pressure is little diastolic on the higher side. Her feet examination normal. Fundus, there is no retinopathy. A1C fasting 170 and the postprandial 275. You see the similar to 9.1 similar study we had. Creatinine is fine with the eGFR 92. You can use most of the drugs what we are using in a current practice. Lipid profile, LDL is more than 165. We need to bring it down, and also we need to start statin in her. And liver functions are normal, so that initiation of any drug should not be an hindrance. So the clinical challenge for this patient is glycemia is uncontrolled. Her dyslipidemia patient has got, and patient is also slightly on the obese side. Patient on the adequate or more than adequate OADS, receiving 100 milligrams sitagliptin, glimepiride 4 milligrams, metformin quite optimal of 2 grams. Atorvastatin 20 milligram probably needs to be intensified or a compliance needs to be checked. Patient is taking a losartan for hypertension, and chlorthalidone is one more antihypertensive for a better control of blood pressure. Family history is the most important. Patient's father had a coronary artery disease at the young age of 56 years, almost similar to her age. Patient is a banker, highly social, has got a predictable lifestyle and eating habit, heavy breakfast before leaving to office and a heavy dinner once she return with a working lunch in the bank. She is compliant with all the medication. She is a postmenopausal, had a urinary tract infection 6 months back that preludes the use of certain oral agents. So what we suggest in this patient, because she had a postmenopausal, she had an UTI, patient is on DPP4, metformin, and also adequate dose of a sulfonylurea, probably the initiation of a premix insulin is a more opt than the basal insulin, because postprandial is close to 100 mg% above the fasting. This is a scenario where premix works better than the fasting. So the insulin initiation option in this patient we will discuss. We know that when postprandial is more than 54 mg% above the fasting, it is ideal to use the premix. If it is less than 54, probably the basal alone should have been good enough to initiate and see the intensification. If it doesn't happen with the basal, we can add on basal plus. And also the psychosocial factor. Patient is quite simple to start premix, quite convenient. And also we can intensify if patient doesn't meet the glycemic targets. And current phase of a life, probably it's a quite important because patient is working quite hectic job. Morning she can take a insulin and leave for job. Again, she can come back and take a one more shot so that her both fasting and the PP can be controlled with a working lunch. So this premix becomes one more important thing in Indian realities. We know that our resources are limited. We need to have a simple and easy, and also intensification needs to be based on what we have initiated. Hence, premix becomes important, and even our carbohydrate content in the diet almost close to 65%, whether it's a north, south, east, central, or a west, the carbohydrate content remains the same. That's why premix is more ideal in this patient compared to the basal alone. So premix insulin like HUMALOG MIX25, which addresses both fasting and the PP, would have been will be an ideal in this patient. That's why in this patient was started on that, and we have a literature to support that premix is better than the basal alone in such glycemic profiles. This is one study wherein compared the glargine with the metformin with the premix twice daily with the metformin. You can see that the baseline HbA1c was same in both the groups. On basal alone, there was reduction of HbA1c close to 1%, whereas with mix with the same baseline HbA1c, the HbA1c reduction is close to 1.3%. This is twice daily HUMALOG mix with the metformin. And also the higher percent, we know that basal is mainly to address the fasting plasma glucose. With the premix, we address both fasting and the postprandial. So even in a premix, the percentage of the people who attain the fasting target is much higher with the premix HUMALOG MIX25 compared to the basal alone. Whether the HbA1c is less than 7%, when you take a fasting of less than 7 millimoles, or even breakfast, or even a pre-meal blood glucose, if you take at all levels, significant attainment is better with the premix compared to the basal alone. Then the most important is the safety data. Whenever we initiate insulin, hypoglycemia is one of the risks. If you see the hypoglycemia risk, overall hypoglycemia is little higher in the premix compared to the basal, but most important, the nocturnal hypoglycemia is significantly comparably less in a premix compared to the basal alone. So though the overall hypoglycemia is little on the higher side, but the nocturnal hypoglycemia is on the lesser side. So this patient was started on HUMALOG mix 10 units before breakfast. Then patient was titrated at a weekly interval. After 6 weeks, second dose of a HUMALOG mix was introduced before dinner because fasting remained on the higher side, and patient was receiving 18 units before breakfast. Further, patient was called, she was taught about the self-monitoring of blood glucose, how to intensify the glucose was taught, and at the end of close to 3 months, patient was taking 22 units of a premix HUMALOG MIX25 before breakfast and 16 units before dinner. With that, her HbA1c came from 9.1 to 7.3%. Patient had occasional history of a hypoglycemia that was preprandial before her lunch, but never severe, and she had gained over 1 kg in the past 3 months, but she had achieved close to 2% reduction in the HbA1c. So every insulin regime has its own advantages and disadvantages. Here I'll be comparing the basal insulin initiation once daily with the HUMALOG mix twice daily. What are the advantages and the disadvantages? Fasting plasma reduction is possible with both basal and HUMALOG premix, but PPG reduction is more with the premix compared to the basal alone. HbA1c reduction almost comparable, but little more we get in a HUMALOG mix because even the prandial component comes into the picture. Durability of a glycemic control is better with premix. Hypoglycemia less with the basal insulin, especially the newer basal insulins. Little more with HUMALOG mix, but severe hypoglycemia is almost comparable or even less. Convenience of initiation is quite easy with the basal. That's why it's preferred in elderly patient with some amount of limitations. Whereas premix twice daily, they need to take twice daily. That's only an inconvenience. Timing of the dosage is almost comparable with both. Titration here is mainly based on the fasting plasma glucose. Here it is both fasting and a PP. Intensification suitability is more with HUMALOG mix compared to the basal insulin alone, because he can only achieve a fasting plasma glucose, not the postprandial. Here we can achieve both the things. There is robust clinical proof available with both with basal insulin and also premix insulin. So when it comes to the clinical trials, there is lots of support. Only the convenience and the patient's glycemic profile decides the use of insulin, whether it's a basal OD or a premix twice daily. We know that starting insulin is just a half work done. We need to intensify so that we can achieve the target. In this patient, the achievement from 9.1 to 7.3 was done, but we need to achieve less than 7. That is the one thing. We need to intensify on the same thing. This is one more example where intensification is done in a patient who is already taking premix twice daily. So this is again a female patient, 71 years old, 15 years of a diabetes with close to 26 BMI, that is obese by Indian standards, metformin 2 grams per day, liraglutide 1.2 milligram per daily. Patient is on a patient was started on a oglibose, but she couldn't tolerate, it was removed. Premix was started 24 units before breakfast and 14 units before dinner, but her HbA1c is still on the higher side, that is 8.9%. So if we look into the glycemic profile of this patient, her fasting or a pre-breakfast is a 142, little on the higher side. After breakfast is quite on the higher side. Hence, the before lunch is high, post lunch is on the higher side, before dinner is on the higher side, even after dinner is on the higher side. Overall, even a 3 a.m. is on the higher side. All these things are contributing to the higher HbA1c. So if we address her pre-breakfast and also an after breakfast, probably most of the glycemic profiles falls in line. So the options for her, what we have is adding a third injection before lunch, but it doesn't address the post-breakfast increase. Switching premix 50-50 at breakfast and lunch, and a premix 25-75 at the dinner, but suddenly we are starting injections. Switching full basal bolus, that would have been ideal, but 4 injections would have been a bit difficult for the patient. Or a bolus insulin before breakfast, before lunch, and a mixed insulin before dinner. This regime does work, but number of tricks are again on the higher side. So before breakfast and a before dinner, mixed insulin and a bolus in the afternoon. This also works, but mostly in this patient, we won't be able to address the post-breakfast increase in the glucose. So what is important is changing the composition of the premix from 30-70 or 75-25 to a 50-50 is an important when you find the post-meal excursions are quite huge, because we Indians mainly we thrive on the carbohydrate. Our post-meal excursions are huge. Probably we require more of a prandial component compared to the intermediate component. So it has been found that the premix 50-50 is not inferior to basal bolus therapy, because basal bolus is the most ideal. In this study, almost both the groups achieved the similar HbA1c reduction of 1.1%, and also percentage of the people achieving the good glycemic target, that's a 6.5 or a 7, was almost comparable in both the groups, whether it's a mixed 25 or a basal bolus with a 4 pricks. And also, none of the patients, either in the basal bolus or a premix, had a severe hypoglycemia or overall hypoglycemia. They are almost similar. So we are achieving the same amount of a glycemic target with the safety data with twice daily injection compared to the person needing to take a 4 pricks. So that's why the consideration, though the ideal is a basal bolus is a ideal, but number of injections are 4 with the basal bolus, they are just 2 with the premix. Self-monitoring of a blood glucose is a less with the twice daily premix compared to the 4 more times with the basal bolus. And patient's ability to inject requires less with the premix because there is only a 1 pen and he has to adjust within that. Here, patient has to use 1 for a basal, 1 for a prandial, makes it little difficult. Hence, this patient was shift to the HUMALOG MIX50. That's a 50-50, which was quite convenient. Probably this was the option which was tried before shifting to the basal bolus, because the studies show almost similar results. So our patient was switched to HUMALOG MIX50 twice daily before breakfast, before lunch, and a HUMALOG MIX before 25 before dinner. HUMALOG MIX50 dose was at 20 units before breakfast, 10 units before lunch, and 25 units before dinner to 10 units before dinner. Patient's glycemia was titrated every week, and at the end of 3 months, patient was requiring 24 units before breakfast, 18 units before lunch, and 14 units before dinner. And she achieved from 8.9 to the reduction of 1.5% reduction to 7.4% at 3 months. To summarize, significant contribution of a postprandial happens in our Indian population compared to the Caucasians with the same level of a HbA1c, and it becomes much more higher as they move towards the higher HbA1c. Premix insulins are quite simple to start. A single pen or a single vial or a single injection, quite effective to initiate. We can initiate once daily. We can intensify the dosage. If it doesn't meet the targets, we can make it twice or even thrice daily. Patients who are uncontrolled on 2 or more oral agents with a flexible lifestyle, it is preferable to start premix twice daily. On weekly basis, we can titrate and we can achieve the targets without much of a hypoglycemias. These premix insulin with the same pen, they provide an option to intensify in the same patient with the same insulin so that HbA1c target can be achieved. 3 times daily premixed with a patient's profile, that is 50-50 before breakfast, before lunch, and with the 25-75 before dinner, almost achieves similar glycemic profile with the similar hypoglycemia instances compared to the basal bolus. Premix insulin provides both convenience and efficacy to the patient, contributes to the long way in achieving patient's glycemic target, as been shown in the 2 cases, wherein in one patient from a 9.3, she came down to 7.4 with twice daily, and with the second patient with the 8.9 with 50-50 twice daily with the 25-75 before dinner achieved close to the 7%, that's 7.4%. I think I rest my talk here. But most important message, premix insulin, whether it's a conventional or analog, quite convenience, quite efficacious. If you are intensifying from once to twice to the thrice, you can achieve almost similar to the basal bolus results, especially with the thrice daily premix injection. Thank you for your patient hearing. Over to the organizers.
Thank you so much, sir, for that enlightening talk. We don't have any questions in the chat box, but I would like to know what is the structure of SMBG that you ask your patient to do when they are on premix?
It depends on what regime they are doing it and what we are recording. For example, a person is taking twice daily before breakfast and before dinner. Most of the time, I'll be titrating them. One is based on the fasting and the postprandial, and the component what we titrate becomes difficult. Mainly if the pre-dinner is there, the titration component will be mainly based on the fasting glucose. Though we consider the post-dinner as an important component, it should not come down. And if patient is taking before breakfast, even a pre-dinner component comes to the importance, and also a postprandial. If HbA1c is controlled, it is good enough. If HbA1c is not controlled, then we need to look into pre-lunch, even the post-lunch. They will be contributing to the higher HbA1c component when you are both fasting and PP are under a control. So pre-lunch and the post-lunch becomes important only at a later date. When you find that fasting and the PP are under a control, but HbA1c is remaining on the higher side, then we need to look into the pre-lunch and the post-lunch. We need to address with intensification, either with 50-50 or sometimes even adding a short acting, or even making 50-50 before breakfast and before lunch.
Thank you, sir, for sharing your experience and presentation.